So the second agent that we're going to briefly mention today is Telisotuzumab Vedotin. We call him Teliso-V. So it's a nickname. You know? This was approved in May 14, so it's amazing. It's like 2 months ago already. This is for MET alterations. And when we talk about MET, you know, everybody thinks about, oh, MET, you know, yeah, standard of care is MET exon 14, and these are the drugs available. Everybody knows about cMET, tepotinib, and, you know, even crizotinib is a MET inhibitor. Actually, the original MET inhibitor is crizotinib. That is, it fell from grace because I guess the CNS penetration is not very good. Because nowadays, the standard of care is to give cMET or tepotinib. But we already know that in China, we have savolitinib and gumarontinib. Even savolitinib now is a little bit known in America because we have studies using savolitinib for patients that have EGFR that have failed therapy and they have MET amplification. So, but anyway, when we're talking about Teliso-V, it's nothing to do with all of this because when you're talking about genetic alterations, MET exon 14 is a mutation. It's in the left. You can see only 2 to 4% of these patients have these mutations in the MET exon 14. There are other genetic alterations like the amplifications, the fusions that I'm showing here. But if you go all the way to the right, we're talking about protein expression. Yeah, this is the same as the technology that we use for PD-L1. We're talking about protein expression. This is a stain that we do in the slide in the pathology to see what is the expression of the MET protein, and usually in lung cancer is around 20 to 25%. So protein expression is not a common biomarker in lung cancer. So that's why this is going to take a little bit time, I guess, to swallow and learn and digest, but you know, it's what it is. And the good news is much more common, you know. As I mentioned before, very few people has MET exon 14, very few people benefit from these TKIs. Now we have a new drug for 20 to 25% of the patients, so now we need to worry to do the testing. And the testing is this one. So we do immunohistochemistry testing, and it's positive, or we consider the patients positive if they have a 3+ intensity in 25% of the tumor cells. Yeah, so it's going to be, a patient is going to be positive, a candidate for therapy with Teliso-V if the MET IC is positive, 3+ and in at least 25% of the tumor cells. We know that this is associated with a bad prognosis, as you can see in the right. These patients that are positive for this staining, they have a much worse survival compared with patients that are MET negative. So that's why it makes sense to develop a drug against this biomarker or using this biomarker, because they help us to understand that we need to treat these patients to save them from this bad prognosis. And the agent again is Telisotuzumab Vedotin. This is an antibody drug conjugate. If you see the upper left, you know, antibody drug conjugates are compounds that they have an antibody. You have in orange antibody. You have a linker, that small piece that joins the antibody and the cytotoxin. And in green, you have chemo. In cytotoxin, this is chemo. In this case, it's monomethyl auristatin. We call them MMAE. MMAE, that's the payload. That's the chemo that antibody is carrying. So the idea is that this antibody is going to go to identify the tumor cell, and is going to look for the cMET receptor, and is going to attach to the receptor. Is going to be internalized, as you can see in the graphic. Once that this drug is inside the cell, the linker will break, and the chemo will be released inside the cell. So this is a fancy way to say that we're giving now intracellular chemo. On top of that, there is a bystander effect, meaning that the chemo that is being spilled inside the cell can go to the nearby cells. So it's not like we need to target all the cancer cells one by one, because there's a bystander effect. Okay, and this is not unique to this antibody. That I'm explaining this is the basic principle of many of these antibody drug conjugates that are available for cancer. So anyway, we don't have a lot of time, so basically, this is the study that was done, that was presented by Dr. Ross Kamich from Colorado in several forums, basically showed that there were two groups of patients, the ones that are cMET high, I already gave you the definition for cMET high, not 3+ in more than 25% of tumor cells, or cMET intermediate, and basically you see that the response rate and the duration of response is much better in patients that are cMET high. And that's the indication for this agent. So patients that are cMET high after we do the tincture. Remember, this drug is for everybody. It's not for EFR patients. You know, sometimes remember EFR patients develop resistance doing MET amplification. Okay, we're talking today about MET expression because that's the most common thing that people get confused. They say, "Oh, this is a new drug for EFR." No, this EFR is wild type, no mutation here, yeah? And as I said, it was approved in May. And finally, the toxicity profile of this agent is very interesting because there are things that are not very common for us, the oncologists. No, one is the peripheral neuropathy, peripheral edema, fatigue, decreased appetite, increased LFTs, hypoalbuminemia. If you think about it, this toxicity profile is very similar to the other cMET inhibitors against the MET exon 14 mutation. When we use capmatinib and tepotinib, we have edema, we have a hypoalbuminemia. So that's why we are targeting the same the same area in the cell, the same target. So that's why maybe it's not a surprise that we see edema, hypoalbuminemia, and all of these side effects. Once in a while, there is some keratitis or something that makes us worrisome because we are not used to see these things. But if you see the grade 3 is very low. In general, even the neuropathy, the grade 3 is very low. So for that reason, hopefully, we will be able to manage the toxicity profile for our patients, and they will be able to have the benefit of this drug. Okay, so thank you very much for your attention. It will be until the next time. Have a good day.